Welcome everybody. I'm Mike Janssen, and it gives me great honor to help drive a discussion today. A few weeks ago, we had the opportunity where Jack Ziegler presented with you total disc arthroplasty and kind of where it sits. I think it was a great learning experience, and I decided we would focus a little bit more on complications. The reason I picked this topic is I think we can learn more upon what not to do from analyzing our complications, and rather than showing you a whole series of good outcomes and excellent outcomes and try to figure out what went wrong on each one of these. Let me just take control of the slides there. I'll back up one. Okay. These are the disclosure statements here. My coworker, Christina Ottemeyer, is going to show a case at the end. And shows some the disclosures for today. So the agenda will first welcome everyone. We would like to talk about complications in arthroplasty. I have a great pool of moderators today that have a lot of experience in this. I'm not going to tag any names of these complications. I've assembled a lot of these over the years of being involved in total disc arthroplasty. So let's get right to it. I've been in practice for just a little less than 30 years, and each year there's a new technology that the physicians like to debate. Whether it's using threaded cages and bone cages and metal, or we have PEEK or femoral ring allografts. Then we saw this whole splurry of a variety of technologies like we see on the side of this explosion of potential disc replacements. And the big difference is disc replacement itself. Each one of these have different features, and each company will tell you why this feature may be best. The reality is a lot of it may be a feature because of patents. It may be the biomechanics. We're still learning upon a lot of where all of these types of technologies place. And I don't have any conflicts on any of these particular technologies, but I do think it's something we can openly discuss. From a cervical standpoint, we've seen a whole portfolio of arthroplasties over the last decade. From devices that were metal on metal, devices that have keels, that got devices that were fills of fluids, devices that are have spikes, devices that are constrained and semi-constrained. Years ago, I used to think that we're going to have all of these technologies and they're all going to fit at a different phase of the disease process, similar to what arthroplasty orthopedic surgeons do for a constrained joint, an unconstrained joint, and have it. And I really don't think after a decade of experience, we have that. We don't really have I think, a technology that works better in different phases of the disease. They're all slightly different and can be utilized somewhat different than that. Jack and myself and Dr. Speedvac and Rick Delamarter published the results about 7 years ago, or on the 7-year follow-up of one particular arthroplasty in an FDA clinical trial. And I don't want to spend a lot of time going over it, but the key here was the results early on were fairly symmetrical between fusions, randomized prospective clinical trial, and arthroplasty. The big difference was at 7 years was the incidence of needing additional fusion at an adjacent level. And I think that's because we all feel comfortable that the primary surgery a patient needs that has a cervical radiculopathy is a decompression. And whether we do a fusion with a plate or a screw or a semi, we get a good outcome. But I think what the literature would start to suggest to us is this technology of arthroplasty, at least in the neck, the big difference occurs after the first 5 years, and we start seeing that at 7. That's the big difference in revisions. Let's just look at, we all learned how most of these trials were done with single-level disease, and now with some technologies have 2-level disease. But the big risks always occur is when we start doing expanded indications for arthroplasty. Most of us that have all been involved in teaching a new technology, whether it's Dr. Lieberman on robotics and deformities, you always tend to get groups of surgeons that come to these conferences, and the first case they're going to do is a 3-level disc replacement or a multi-level hybrid or something as soon as they get trained and get access to technology. So we can learn a lot by that, by trying to stick with what we I think became really good at running trials. This is a 59-year-old physician that had a previous cervical fusion a decade ago, I believe with autograft, and now has a classic adjacent level disease. And historically, and when I was a fellow and early in my career, the treatment of choice is to take this out and do an adjacent level surgery. And I think even though this wasn't what the real indications for, these patients do well, I think, with expanded indications of what we have learned from, rather than what just extending to another fusion, it may be a much better treatment for us. I think they have a quicker, faster recovery, but there are substantial pitfalls that we can learn from that by looking forward. There's another classic example of what do you do with a patient we thought we had a good solution on 10 years ago. This patient had a C3 to C6 cervical fusion. The patient did great. And we all think it's a high five, and we all think that we get 90% success rate. The guy fused over those levels, but then he comes back a decade later with a myelopathy and cord compressive pathology, and now at a different level of 2-3. And how do we manage these? Do we do a decompression from the back and infuse him? Do we take this plate out? Do we now use technologies such as zero profile devices so we don't give him further dysphagia? And I think we can take some of these expanded technologies if we learn and how to do them right way, and maybe do something simple. This is a guy that at 2-3 we ended up doing an arthroplasty on rather than a additional level fusion. I think the incorporation rate into the device is much faster than additional fusion. These are tough to access, I think, sometimes up underneath the jaws and the retropharynx. But these are other alternatives that we've taken what we did learn and make expanded. But there are issues with this, and this is what we've seen on what's the right thing to do, because not everybody has levels that are contiguous that have disease. Not everybody has a 5, 6, 6, 7 pathology. Some people here, in this case, the surgeon felt that the primary pathology was at 2-3 and at 6-7, and so they treat each disc of where it's at in the phase of the disease. I think that's the key. I view disc disease like dental disease, and you got to look at where it is in the phase of the disease. I tell patients that you go to a dentist, and sometimes you need a filling, sometimes you need a crown, sometimes you need an extraction, and we have to look at each disc and where it's at in the phase of the disease to see what our best tool is. But even with all this technology, patients come back with further disease. And you can see on the right side, the biggest limitation we have is imaging. We all use MRI today so routinely, and you get an artifact like this. This is even a low-level artifact with most of the implants that we put in. We've all seen cases like this, and this slide I flipped because it was said 1994 on it. And so this is a patient that had a multi-level fusion and then ended up with a problem above and below. We created a straight neck. The patient's had a previous laminectomy, probably has no lordosis. You can see we've learned a lot over the last 20 years on a better way to manage that. And maybe when patients have these 2-level diseases like that, we can take some of this new and advanced technology and offer them a better alternative to keep the motions at the levels above and below if it's the right thing to do at the right phase of the disease. But you got to pick the right implant. You got to pick an implant that's going to be secure. You got to pick an implant that gives good primary fixation and can control the motion, because we may not be trying to restore the segment back to normal. We're trying to retake a disease segment, so we got to think about what the right implant is to do that. But there's always problems. And here's a clinician that decided that maybe the surgeon informed me that he thinks that he has a better understanding of which technologies go for different levels and which technologies treat different phases of the disease better. And so there's a mixed match of technologies, of Bryant discs superimposed because of the concerns of the facets with a semi-constrained disc above. This is where I think we start having issues that we can learn from, because we're still learning how to manage these, and now we mix technologies. But nonetheless, these technologies that we have makes it difficult for us when the patients come back with pain or symptoms to get good imaging to really know the right treatment. Probably in the near future, we'll have a better technology. Many of us were involved in a clinical trial, and I don't have any conflict, but I was involved in this trial where this is an MRI compatible disc, which I think will be exciting. It's still in the FDA evaluation, so it's not available in the United States. But you can see this implant right here hardly has any artifact whatsoever on MRI imaging. And so maybe we will move into having a better technology with MRI imaging and still know which technique to do it. This is just so happens to be a ceramic device that's on a peak, and we enrolled all the trials in both 1 and 2 levels, and now we're just kind of waiting to see what happens for its ultimate approval. But we can learn a lot. This gives you an implant to take a look at, and you can say, oh my gosh, the one on the left, the surgeon had a previous fusion and they put a device in. You can see it somewhat fell into kyphosis. Maybe there was implants burred. The implants migrate a little bit to the back. It isn't the ideal position. You can see the one on the right. This implant came apart and really was probably a mixed fit. It's easy to put these implants in, but getting the spine released and putting them in so they stay and they get secure. This reminds me of all of the horrible, horrible x-rays we used to see when plates first came out. We saw plates that were broke. We saw plates that were too long next to the disc spaces. We saw screws that were going in the wrong direction, telescoping plates, and we can see the same kind of thing once all these new technologies come being released. And sometimes we make bad decisions. And this patient was referred to me and had a previous cervical fusion, had 2-level disease, and the surgeon chose to put a unconstrained type of a device above and below. And I think what I learned from some of my colleagues here is that you're probably just asking the implant to perform, to do more than it can. You take the ALL out to do this. You probably resected the PLL to decompress the spinal canal. The facets got over-distracted. You put a semi-constrained or unconstrained disc in like this, and it just can't withstand the loads that are applied to it. And so, therefore, it tends to fail. If you take a look at the right X-ray, the AP, it looks like the end plate, probably at the bottom end plate may be closed, the top end plate may be off, the poly kind of went one way, the neck kind of slipped the other way, and probably just was a bad choice. But most of us have done this in other types of cases and it works, but this is just a bad example, not necessarily for the implant, but it was probably, clearly you didn't get sagittal balance, clearly it was probably the wrong implant for the wrong phase of the disease in this patient. But all of these have issues. Let's take a look at the top left one. The key with arthroplasty that I learned from Jack and Rich Delamarter is you want the largest platform and the smallest height. What we learned with arthroplasty was the most common size of ACD and F grafts were 6 or 7s that were being sold by most of the allograft business before we got into arthroplasty. And if you put an arthroplasty into that big, they don't move. Because when you put an arthroplasty in that's 5 and it goes into flexion, the posterior height's about 7. So you want the smallest height and largest platform. So the top left, you can see either A, there was too much milling done, B, the implant probably was too small, the superior implant was close, the inferior implant's off, and then the segment falls into kyphosis, the top of the axis of rotation is probably off, and you can see at 7 months it's less than ideal. The next one on the top, let's look at that. You got a total mix match. If you look at the anterior posterior height from the back of the disc space to the front, the size of that implant is way too small. I tell a patient, that's like having a disc that's the size of a quarter and you put in something the size of a nickel. The inferior implant subsided, it's in kyphosis. The next implant's not even back far enough. So the two harmonious balance here is way off in this whatsoever and isn't going to do well. The bottom left picture, well, that's another implant. You can see it subsided into the bone. Either the implant's too big, there was too much milling, it was the wrong implant. The middle lower one, the implant's way too small. That's like taking a teeter-totter and putting the wedge way off to one side, and it's never going to function. The bottom right, the implant's too far to the back. Half the bone is milled away. So even though we have all horrible x-rays, we can look at each one of these and kind of have a good idea what was wrong so that we can hopefully prevent that when we make these decisions to put these things in and can learn more by this. Here's another one that we've chatted about in the past. You can see horrible issues that the implant is in kyphosis. It's subsided. The implant's half into the canal. It was secured with a keel. I can't remember if you look at the left set of x-rays if that's where it was or that's a different one. But then on the right, you can see the whole implant back. There was a number of early publications from Michael Meyer in Germany about keeled implants, that if you put the implant back too far because we used to use a chisel, that some of these can actually drift back, break out the back of the body, and it requires a lot of finesse. Remember, putting these implants in is not the easy part. It's got everything has to be totally perfect to get a good clinical result. We already mentioned this case, so I'll move on. Here's another patient. I think this is one of the best benefits. When you see patients with multi-level disease like this at this phase of their disease, historically we would manage them with cages and plates and a variety of things. And I think if you can get good balance and you can find ways to put implants in, restore the lordosis, get a quicker, faster recovery. When we do 4-level fusions, we worry about the success of fusion rates. But I think you get really great osseous integration into most of these current hydroxy-coated implants really quickly today, regardless, and may be beneficial. This dates back into the 90s when I had just started in practice. We used to see these unconstrained plates like this. We saw screw breakage. We saw all these horrible x-rays falling into kyphosis. And I think today we learn with a lot of different implants, maybe there's better ways to manage these and avoid some of the horrific complications that we have seen compared to what we looked at for fusions. Let's take a look at this guy. This is a 36-year-old guy that I took care of a long time ago. Has some changes looking at the implates and the morphology of the bodies of 5, 6, and 7. He had a C5 weakness. He ended up with an arthroplasty. It probably wasn't the ideal case early on. He's kyphotic. He's advanced degenerative. He can't restore the lordosis. And probably wasn't the best choice the patient really wanted. And he went to someone that had trained him recently in total disc arthroplasty. He put a disc in, and we always wonder how stable they are. It was about 3 months later, if I recall, he was driving a car in Colorado at probably Dallas speed at 120, flipped it over going from Steamboat towards the Denver. And you can see here he ends up with a jump facet at the level above. It's kind of hard to see. And both of the implants distorted the polyethylene. They didn't dislocate because the polyethylene is attached to the inferior plate and fell into kyphosis. But the patient ended up with a jump facet at the level above. You can kind of see that there. I don't have the CT with me when I put this together. And you can see how the poly was all completely rounded off at the bottom one because I took these out. And so even though the patient was in a substantial issue, he failed at the level above before the implants completely gave away, ended up having that reconstructed, and then the posterior tension band where the facet was perched and fixed in the back is kind of a salvage procedure. And so we can learn from that. This is a 30-year-old smoker. Has a routine single-level pathology. He's got a disc herniation. This is the one that, Jack would tell me is a chip shot, and when you teach a course, and hopefully the surgeons will go away and put them in. You can see here the implant was put in, and the patient has a semi-constrained device with a keel. Maybe on the bottom right picture, the axis isn't quite right. If I look at the front and back dimensions and then figure out what the top of this dome is, maybe it's not quite in the ideal position. It may not get enough flexion. I think it could be back a little further. It may not move quite so much. Yeah. But you can see that's exactly what happened here. I don't know if it's her smoking. I think maybe too much milling occurred. The implant looks like it's subsided. Look at all the kind of osteolysis around the superior aspect of the keel and the implant, and it created a cavity. And you can see clearly this was a mixed match and wasn't going to work, and that's the outcome. And now the revision is to take the surgery. When I took this out, it just almost fell out once you opened it up, and there was zero integration. So this patient was converted, as you can see, to a fusion there. And people always get concerned about it. What's the fusion rate? I haven't, I've only done a handful of these to revise these and take them out and create a good biological environment. But to some extent, we should always be concerned because you got to scrape this out because it may get a little membrane around the ones that lose. Look at this. This is a patient that had a...
Mike, can I interrupt you for a sec? Did you culture that last case?
Yeah, we cultured and never got any growth at all out of that.
Did they do the 10-day to 2-week culture to looking for C. acnes in those days?
I can't remember that. I can go back and pull that up. That was about 5 years ago. I can't remember if they did that. I scraped that out. It kind of had this membrane kind of all over it when I pulled that implant out.
Yeah, I don't think C. acnes was on the radar screen 5 years ago. So I know we weren't. When we did revisions 5 years ago, we didn't do the extended cultures. It's more on the radar screen now.
Yeah, that's a good question. That would be good to go back and take a look. I mean, I don't recall that at all. Any other comments on how to manage these and take them out and revise them? Okay. This case here, if I recall, was a surgeon that, somebody went into a course and had this surgery. And I remember Jack Delamar showing me, talking about this patient. You can see the implants really in a bad position. It's kyphotic, it's too small, it's subsided into the back, and you can see that the implant's in flexion and the segment is in neutral. That's where the mix match is. No arthroplasty orthopedic surgeon is going to put a knee or a hip in an abnormal position of the implant compared to the host. And you can just stare at this and immediately realize it's not going to meet the ideal needs. This is a 57-year-old patient that had 3-level disease. Ended up having a surgery. You can see here, it looked like there's a picture of the drain, and they put each one of these in a little bit of lordosis. How do you know? Well, you can see it's a little bit more open in the front than the back. They probably milled each one of the superior implants back just a little bit further and lined them up. But you can see how the inferior implant here at 6 weeks subsided. Maybe there was a fracture between the bone, between the keels, because if you look at the keel between the top one and the middle one, there's just a little bit of bone left there. Also, when we first were doing these, we were using a chisel rather than a mill. That may have cut a fracture there, but nonetheless, you can see how the whole implant subsided in to give what it looks like a reasonable good outcome. I also wondered if the bottom one may be over distracted as a 6 millimeter rather than a 5, and may have been taking up too much space for that to occur too. This is a bad judgment case too. A patient had this long fusion up above, has this case below. Surgeon comes to a conference, says, "Oh, this is a great technology. I got a patient that really needs it. I don't want to do another fusion." They can make the x-ray look great, as you can see there in the middle. I mean, but the facets are way over distracted. There's a huge amount of load going to be on this implant. The far right x-ray, you can see where they put the pin in, they distracted this out, and you're asking this implant to do a lot. The original equipment of this disc at the bottom of this long fusion couldn't withstand the normal loads. To stop and think that we've developed an implant that's going to withstand those loads is somewhat concerning, and you can see here it didn't take long before the whole implant starts to slide forward. And if I recall, we ended up revising this. It was sent because it was way over distracted and wasn't going to do well for the long term. In cervical spine, we've talked about all 5 of these kind of disasters. The top one here, where both of the polys failed and the jump facet. Number 2, where the implant was in the wrong spot, got kind of this osteolysis around it, drifted forward. Number 3, where there was too much milling, probably in the back. Wrong size implant, fell into kyphosis. Number 4, you can see where the keels probably wasn't the best. There wasn't enough bone there. Too much, maybe it was too tall, caused it to fail. And number 5, where the loads of this implant, because the own original disc didn't work, probably were all less than ideal and good judgments as it goes forward. So what have we learned from looking at all these mistakes and done a lot of different discs and looking at them? I think it's a fantastic technology. Revision strategy should always be there for you to take a look at. Putting a disc in is a very precise operation, a lot of preoperative planning, making sure it's perfect to avoid some of these kind of things that we really have. We've all been doing a lot of these multi-level applications, which is off-label usage. We should be really concerned, like the middle x-ray, of the loads. When I look at something like this, I go, the patient's original equipment isn't going to withstand those loads. So I don't know if in my hands I have a disc that's really going to do that. And where should we be applying a lot of these? Because most of the complications occur to judgment. I think the cervical spine, they also occur to the techniques. And sometimes we don't spend the amount of time that we should if we're going to be doing a fusion to do that. Before I go into lumbar spine, I think I'll let our moderators open up any questions, discussions, and any criticisms of the kind of things that we're kind of outlining here.
Hey, Mike, I think that those cases were very representative, but you can sort of classify them. All the mistakes could have been avoided. Number 1, if they were satisfactory preparation of the end plates, and we try to avoid using any power instruments, because if you violate the end plates, then you make a stress riser, and several of those showed subsidence into the end plates. And the second thing that at least I've learned is that in the beginning, I was very timid about doing the releases. And if you don't do a satisfactory release, which means removing the posterior longitudinal ligament, making sure you take the posterior aspect, the uncus, you're never going to be able to restore that disc height. Obviously, you can't stretch the facets from the front, but what you're trying to do is at least to be able to distract in parallel the end plates. And then the last item is to make certain that you fill that disc space with the largest possible implant and to make sure you don't place it too far posteriorly. Make sure you place it in the what we like to say in between the goalpost or the uncus. And these are basic things, but as you said, it's a very technically demanding procedure. And it's, as we've all experienced, those of us that have taught the courses, it's amazing. You teach a course and people go out the first time and they stretch the indication rather than learning all the nuances. And each particular disc is different, and each one requires attention to different things. So, you know, it's a great technology, but as you say, you can't expect the world from a technology that is just replacing the anterior column.
Mike, a couple of questions from the chat room. Vince Arlett wanted to know what's your cutoff for osteoporosis on the DEXA scan for pre-op patients?
That's a really good question, Vince. I historically do not get a DEXA scan on cervical spine patients. I guess if I haven't seen that as a big problem. In the lumbar spines, we all, you know, have our philosophies on how to do that with, you know, less than -1 or 1.5, but I don't do that in the neck. I don't think I've ever, knock on wood, got a DEXA scan on a cervical spine. Do you guys do that at TBI?
Mike, it's interesting.
Yeah, Mike, we just did a paper on it, and it's about to be published. And we look back on a few hundred, and we had a couple that maybe influenced our decisions. So we've really, we agree with you. We've kind of stopped doing DEXA scans. You know, the two things that were taken from the lumbar studies to the cervical were DEXA scans and facet arthropathy. And there's another question on facet arthropathy that don't really seem to influence decision-making on cervical arthroplasty. Those kind of the two things that were just pulled over from the lumbar studies. I don't know what your feelings are on facet arthropathy, but that's another one that unless there's instability, we don't really pay attention to the facets.
Scott, I did want to add one thing about facet arthropathy. If you see on the MRI scan, it looks like a big fat facet joint, then you ought to get a CT scan, because if it's a very degenerative facet, like a grade 3 or 4, no, you shouldn't be doing it. But mild degenerative changes don't make a difference. Now, for the fellows that are on the call and the docs that, you know, are questioning about the bone density, basically the cutoff is a T-score less than 2.5, meaning that if they have osteoporosis, then no, they shouldn't be a candidate. But as you said from our study, and Mike saying that he doesn't do it, if they have a history of fracture, whatever, then, you know, you need to study those folks. But those generally are not the people that were putting these discs in.
Yeah.
So what's your age cutoff if you don't have a DEXA cutoff? Okay, what's your age cutoff?
What's minus 2.5 is in the IDE study, Vince. So below minus 2.5, they could not be enrolled. So it's technically an off-label use. But as we found in practical life, that only 2 patients out of a couple hundred actually had an issue from osteoporosis. So unless they have medical conditions, they've been on long-term steroids or had early menopause or a history of fragility fractures, those people will still get a DEXA scan pre-op. But for the general population for cervical spine, we stopped doing it. It's just not cost effective, even though it's a cheap test.
Vincent asked about age cutoff, I think, too. And, you know, I think it's more physiological age, as we know, Vince, than just chronological age. I mean, I've put disc replacements in patients that are very active, live in Colorado, ski, and do everything, that have a single level problem. If they don't have other disease, that up to 70. But that's rare. Most of the time, they're fairly spondylitic when they're at that level. And I think I try to tell them that a disc is probably the wrong operation for them. So I think,
yeah, I mean, we saw a lot of these cases when we went over to Europe, and they're a little bit more cavalier. But, you know, what actually had me doing older folks like you, Mike, I mean, not over 70, but in that 60 to 70 age range, were actually retired or even still active physicians that said, you know I'm spondylitic, but what's the worst thing that could happen? And you say, you could autofuse, but you could also retain motion for a few years. And so, you know, for 1 and 2 levels, I wouldn't do 4 levels on a 70-year-old, but, you know, for 1 and 2 levels, as long as you talk to them and say, you know, yeah, you're at increased risk for autofusion just because you're pretty spondylitic. You know, I think we've extended it up to the age range that you said, Mike, not really beyond 70.
And listen,
would any one of you guys consider using Forteo in these osteoporotic patients and do a disc replacement?
You know, Neil, we see it so rarely in the cervical patients that, you know, as we said from our study, it was only 1 or 2 out of several hundred. In the lumbar spine, yes, we do use Forteo a lot.
But with the disc replacement, we do it with it? Disc replacement
Yes.
And give them Forteo?
Yeah, we'll pre-treat them for 3 to 6 months with Forteo for lumbar, and then consider doing them. Their DEXAs don't change, so you kind of have that leap of faith that Forteo has done something.
No,
but,
Scott,
you know, it's still a bit of a leap of faith.
I disagree with that. If you get a scan in 3 to 4 months, you will see a change. I had a patient right now that started out at 2.5, and after a year of Forteo, he came down to the individual levels of the vertebral bodies. The highest was -1.8, and the lowest was -1.4. So we're letting them go a little longer because you can treat them for 2 years. So you do see a significant change with the Forteo.
Well,
I agree at a year or two, but at 3 to 6 months, you're not going to see a ton of change.
I should have clarified. We had serial scans from 3 months, 6 months, and then a year, and each one showed improvement.
I mean, I can tell you in deformity surgery, we've been doing it with Forteo. We'll do it and give Forteo for 2 years. We've actually stopped waiting unless it's more than 3. And it seems to work. I agree with you. You don't see it on the bone density as much, but it works clinically.
Mike, you want to just comment on your heterotopic ossification prophylaxis?
Yeah, you know, when we first started doing this, it wasn't really on our radar screen upon HO, and we saw that in the literature, especially in the European literature, that the HO rate was substantial. We looked at it internally within our group, and it appeared that there was a couple sites that had a little higher incidence of HO. We thought that it was probably due to technique. A couple things. Number 1, to not use the burr. Number 2, to have used bone wax. Number 3, to have a larger platform. And number 4, we started putting them on, even though it wasn't part of the trial itself, with anti-inflammatories. So those are the key things for me, is to try to stop the bone bleeding, especially on these keeled prostheses with some wax, to try to leave the periosteum there instead of subperiosteally exposing it all. And to try, I still put my patients, even I can't tell you it's truly scientific, on anti-inflammatories of naproxen for 2 weeks afterwards. Those are the big key things. But you clearly see some of them will still autofuse. Some of them look like there's a little beak, and then you get a CT and they don't have it's not autofused, it's ankylosed. And we got to realize that we may not stop the process of ankylosis and spondylitic, but we can control it with our technique, is kind of what I think.
Hey, Mike, there was another question from one of our fellows, Alex Satin. He had a question about, what about the indications for C2-3, even though it's quote unquote not in the IDE? Do you have a problem doing it C2-3?
Well, I did one, and I showed you a little bit.
Yeah, I know, but
it's hard.
You have the flattest inferior end plate of C2 I've ever seen on that patient. Usually they're hypercupped.
It's hard to get them in. You got to make sure you can get up underneath the pharynx up that high to put it in. So I've only done a couple. I've done a number of them at 7-1 too. But again, it's not very common. I think, you know, you either, in this case, you either fuse him and decompress him and or try an arthroplasty. I think the advantage of the arthroplasty is that when the bone grows into the implant, it's probably quicker, faster than waiting many months in the lever arm on putting a fusion in. But the access is always the big key. You have to be able to make sure you can get an access, and not everybody you can do that.
Okay.
Want to move along, Mike?
Let's just go through short slides, and then Dr. Ottemeyer is going to talk about a case too. I'm going to just go to lumbar, and we'll spin right through this. Some of these things we've already talked about, and we've already Jack went through some of these. So I'm just going to skip through the first 3 or 4 slides and get right to the issue we're here to talk about, which is complications. I think the biggest key when you talk about arthroplasty, when you're looking at complications, is that when you train surgeons, they think, oh, well, I can pound in an A-lift graft. I can just pound this graft and this implant. It's the same. And I try to tell clinicians it's not a product. I tell patients that. It's a whole different way of the philosophy of the way we treat the disease. And the most important single thing is the release. And we know that if you can't unload the facet joints like this from the back, you didn't get a good release, because that is the key. The implants don't move if there's not a good release when we do that. And that's where most of the complications occur that we'll talk about at the same time. When do we do that? This is a classic example of a good case, because I want to show some complications. It's a 59-year-old guy, had complete collapse of the disc, very good candidate for an arthrodesis. He didn't want an arthrodesis. We all know that there are certain patients that know the technology and the surgery that they want. So the sets looked reasonable. He ended up with a single level arthroplasty I did about a decade ago, did fantastic, and still is doing very well, did not autofuse, and I'm very happy with his overall clinical results. This is an interesting case of what do you do? This is a 49-year-old female that I know through offshore boat racing. This is a third time disc herniation, third time. And she's got this huge fragment behind the canal. Doesn't want to go through this again. And I've done her previous laminophragmectomies. You can see on the lower right how big the fragment is. I think these are great cases. If you do the right device, you get a good exposure. You can reach behind the body most of the time, take it all out, and reconstruct this with the motion preservation technology rather than offering her a fusion. And I think they can do well. Interesting is we can't please all patients. I remember seeing this patient shortly after I operated on her. She said she went back to work, and a short time they owned a company. She was doing a stationary bike. She was doing everything, but she only got pissed at me because I met her in an offshore boat race, even though she's 49, because she's pissed about her incision. She can't still wear a bikini. So even though I met all of her other needs, sometimes we don't meet 100% of the needs of the patient, even though I think you get a good clinical result. She ended up getting her scar revised. This is an interesting case on what you do. This guy has a 5-year history of back pain. You can see he's got this defect at the inferior aspect of 4. He's got little calcifications at 4 or 5. He sits most of the time, really miserable. And what do you do with a guy like this? You get someone that sits a lot. And this guy I ended up doing early on, I spent a lot of time thinking about it. If you're going to do an arthroplasty, you want to make sure the implant goes all the way to the back so that you can fill that in. I was going to bone graft this, and we didn't. He's done very, very well and didn't have, but those are really stretching what we did learn from some of the indications on how to manage these patients. Now, problems occur sometimes. Let's talk about, you don't want to do these patients that have spondylolisthesis. You can see this is older technology, no question, but here patients have lost the posterior tension band in the back with either purse fractures, either preoperatively that were missed or intraoperatively due to the magnitude of the way you do the distraction. Nonetheless, think about this as a tripod. One leg is the disc, 2 legs are the pars or the facet joints. When you've got a fracture in 2 of them, the loads on the disc are going to fail. That's why patients get pars fractures over time. The mechanical loads on their own equipment fail, and usually these implants won't withstand the loads. You also, it's the wrong indications. I mean, this is a patient that had a previous fracture. Surgeon thought that'd be reasonable to treat it with an arthroplasty when the disc degenerates. It won't work. You can see how the implant isn't going to function. It isn't going to sit right. This is not how we can then say, do we have a new technology for a problem that we probably think should go back to our historic methods for treatment. Sometimes it's the wrong technique. You can see on the bottom slide, I think this was a great implant. I don't have as much experience as Dr. Blumenthal and Dr. Geyer did. I only done a handful of these, but I think it's more of a mechanical nucleus replacement because it's asking this implant to do a lot when you take the ALL out, the PLL out, or release it. And then if you combine it like this where there's a pars defect there, you can see that the implant's going to fail because it needed some sort of a tension band reconstruction. This is a classic example of a lady I thought would be quite easy. I did this case, a patient had terrible back pain, had a terrible 4-5 problem, and she had had a previous mastectomy for breast cancer, and they used her rectus muscles to flip her up at the time instead of implants to give her breast tissue. So I said, this will be easy. There'll be no rectus to dissect through, but you got to think about it. When there's no secondary stabilizer such as a rectus, everything comes out. These patients need secondary stabilizers, whether it's their core muscles. Since we take the ALL out, we've resected the PLL, that we can't expect this to last and to work. Good learning case, made a terrible mistake. Here's another example. Patient has an arthroplasty in. I think it looks great. It's fit well. It was a very collapsed disc, very well distracted, but sometimes these don't stay because we're asking the implant to do too much when we do a complete release. Similar. So we can learn a lot by that on picking the right implant, the right technology, and at the right phase of the disease. This is an implant where the two of them were placed, as you can see, and both of these implants tended to dislodge for maybe a variety of reasons. I was not involved in this particular case, but I think we can learn about it. And you can see how sometimes they require major revisions, and neither one of the implants were stable and needed some sort of a reconstruction. This was an in-block device that was tested in North America, put in all as one unit. It's got a keel, it's metal on metal. But you can see to drive this implant in here, the superior aspect was all the way back up in the vertebral body. It's into kyphosis. And maybe even though it's a posterior axis of rotation, it's either the implant, the release, the ability to hold it open, or the way the implant's inserted. And you can see some of these just clearly were the wrong technology for the wrong patient, the wrong phase of disease, even though we were excited. All of these implants have a sweet spot. And we learned early on in the publications that maybe within a few millimeters of putting it in. I think the keel gives you the ability to hold that sweet spot better maybe than some of the unkeeled prosthesis, but you have to really take a look at it, and we'll talk about that in a minute. Everybody harps on autofusion. And, you know, clearly we can see that the 4 or 5 implants probably way too small, and it may fuse all the way around it. Or is that just a natural history of their disease that they manifested at the level below? And even though we feed a phase of the disease, many years later, in this case, it was a decade and a half, you can see how it ossified, but so did you see the same thing at the level below. Key also fact, probably we learned a long time ago, even though we didn't know that, I think 20 or 12 years ago, these implants are way too small. I tell the patients, if you've got an implant the size of a $50 and you put something in the size of a quarter, you're going to get this autofusion, and we even learned that in the cervical spine. But you always have to maintain frontal balance. And this is what happens a lot of times as surgeons we were teaching would see a patient like this, and you can see on the lateral we can make it all look right, but you can see this is completely out. Either whether they curetted this all out, whether the bone quality was too bad, the body's reacting here, you can see to try to autofuse circumferentially around that, and both of them fall to the left and the right to maintain that balance. And sometimes surgeons think they're still right in the midline. This is a non-contiguous segment, and 5.1 probably isn't ideal. It's probably closer to the sweet spot, but I don't know, it's hard to imagine how the vascular exposure was so far off at 3.4 that someone put an implant and felt at least that's where it went. Because as soon as you can't get that kind of exposure, you want to avoid the technology and the complication, just bail out and do a fusion or a lateral or something else. But when you take a patient here that has a straight spine, has an advancement of their disease, and you decide to put an implant in, this kind of a technology, I think, is like stepping on 3 bowling balls at one time. One goes one way, the other goes the other way, because the spine wants to straighten up and balance over this. And this is where we saw many of these complications. 2-level arthroplasty, I think, in the lumbar spine is much more difficult than 2 routine single levels, because balance is everything, and getting the segment balanced. We spend a lot of deformity surgeons, and Ezzy is an outstanding, and Vincent Arlea is on here today, is we talk so much about balance with multi-level fusions, and we're learning a lot more about how to balance when we do arthroplasties, because you can see what looks good initially doesn't look great here on the far right slide a short time afterwards, even though the implant looks great, but the overall balance of these unconstrained devices were less than ideal. Anytime a surgeon shows you these great x-rays, we could all be critical, saying maybe it's not back far enough, maybe it's not quite lined up, otherwise it's okay. You got to get the APs, because you can see here that you can't pick those technologies and the judgment up on whether they had a tough time getting the implant in, curate it out too much. Look at the size of the implant on the inferior aspect of 3 in relationship to the end plate. Clearly, there's a mixed match, and the forces of half the body weight going through to get this in is what's going to cause that. Here's a surgeon that would tell me, Mike, look, I did a great job. I did this 3-level implant. Okay, it's probably not back far enough. The axis of rotation isn't ideal. Maybe it's not good enough release. But when you get the AP, you can see the orientation's off. And they did a lot better job at 4.5. A little better at 3.4, but 5.1 was way off, whether that's because of the vascular anatomy or something. So in lumbar spine, I think it's a great technology. I've learned from most of my mentors that are on here. But again, the complications are the wrong indication, the poor planning, maybe not the best vascular exposure, not a great release. And I think those are the real key things that we can learn from upon doing arthroplasty and prevent these kind of complications. Great. I'm open for discussions. And then we got a case by Dr. Ottemeyer before we have to wind up today.
Mike, it was fun to see some of the original Charité. And for those that were not used to or not familiar with the disc replacement, when we started to use the Charité, you showed a lot of the smooth ones. How we thought they were going to be held in by the little spikes in the front and the back is beyond me. And then later on, after it was approved, I believe, that's when they started to have the porous coating. Scott and I still have a fair number of folks that are 14, 15, 16, and even, one patient that's 20 years out that are still doing okay, but it was a very, very difficult prosthesis to make look good. And we have lots of ones that don't look good. So, but we learned, as you said,
Yeah.
They were all too small in the beginning, and but that was a great job.
Mike, you did a good job highlighting how a lot of the issues really come down to indication and technique, that it's really not an implant failure in most cases. It's really a surgeon's failure, either picking the wrong patient or just not following the operative technique and violating too many taboos. It's a famous saying that arthrodesis will cover up a surgeon's sins, but arthroplasty magnifies the surgeon's sins. And you see it a lot in lumbar disc replacement, particularly multi-level. So you did a good job of showing us these examples that made us all shiver. Thank you.
And one other thing to remember, the definition of Mike, the definition of an orthopedic surgeon is a surgeon who sees the procedure one time and the first time he modifies it. But arthroplasty is not one of those procedures you're modifying. We've worked out all the kinks. All of us have.
But we've all taught courses. And even though we were only teaching courses for 1-level lumbar arthroplasty, we always would run into surgeons that were going to go home and do a 2-level or a hybrid the next day.
I mean, the classic was, I remember teaching a Charité course, and this neurosurgeon said, well, I have a 2-level scheduled on Monday. I said, whoa. I said, you haven't done any? He said, no. I said, it's not the right thing to do a 2-level. And I sure it didn't look good, but.
Mm-hmm.
You want to go on with your case?
Sure. Christine has a case. Dr. Ottemeyer has a case. And then, and some of you may have seen this before, but I think it's a great teaching case. I learned a lot from this case. And then from there, we can finish up some discussion.
Excellent. Thank you so much. It's an honor to present today. I'm Christina Ottemeyer. I'm Dr. Janssen's fellow this year out in Denver. We'll get started here. Advance my slide. All right, here we go. This is a case of a 49-year-old female nurse back in 2007 that came in with single-level disease at L5-S1, was treated really uneventfully with a pro disc at that level. She was discharged at 23 hours out of our surgery center here next door. Unfortunately, she suffered a fall about 4 days post-op, of course, on a Saturday morning, and presented to the emergency department with acute onset of severe low back pain. X-rays were obtained at the time, demonstrate a coronal plane pincer type fracture of the L5 vertebral body. She did not have any neurologic deficit or anything at presentation. Subsequent CT was obtained. Axial, sagittal, and coronal cuts are shown here. The axial cuts don't show any extension of the fracture into the posterior elements or the pedicles, and the CT just redemonstrates the coronal plane type fracture here. So I'll turn it over to the panelists, how they would treat this, whether you would perform an anterior revision type or stabilization, if you would do posterior stabilization, combination of the two, or phone a friend.
Can you go back one slide so we can see that?
Yes, sir.
While you're doing that? Okay.
Did you have a DEXA scan pre-op?
Yeah.
I think so. I can't remember, to be honest with you. It was in 2007. I can't remember.
Mike, was there an end plate violation during the implant?
I don't think so. This is one that I did when we were doing live surgery transmissions.
I thought so, yeah.
So, I mean, I had Rick Sasso and these people critical staring at us in the amphitheater when I did this at our surgery center, and I thought it was like it was a home run. It was a straightforward, simple case, and you may have even been moderating it, and I didn't think there was an issue till like 3 days later. I mean, it just went in just perfect.
Thank God the meeting was over.
Yeah.
Well, the other good thing, thank goodness, is it's only 4 days post-op and you can get back in the retroperitoneum without much scar.
Yeah.
So Mike, we see this, right? We've seen a few of these. So when you do multi-level now, how do you feel using a keel implant like this? And is that raise any bigger risk on the intervening body, or do you choose another disc?
Well, that's a good question, Neil, but how could you, let me ask you this. If I gave you a cadaver spine and a chisel with that trial, how can you create intraoperatively a fracture 90 degrees in relationship to the chisel?
No, that's fair. I mean, wonder what stresses go through it, right? Clearly, there was a stress riser here for whatever reason. It happened, right? And that's the point. It happened really fast. So it has to be an intraoperative stress riser.
Yeah.
It happened within 3 days. And so that's the way, I'm just throwing out a theoretical discussion I have in my head. I don't know. What do you do?
I mean, I worry about whether you cephalize that chisel and that creates it. I mean, there's of course no different than cutting the pars in the back or breaking the pedicles. We all have realized that with too much distraction or less than ideal distraction. I mean, but this one amazed me. You know, I always joke that the best news is that years ago you used to make phone calls, and I sent this picture around to a lot of my friends and colleagues, and everybody gave me the same answer. I don't have any idea what the hell to do, Mike, but just let me know how it goes. So
I promise you, you're not the only one. I've seen two more.
Okay.
So don't feel too bad.
So what do you do for this, Neil?
You gotta take it out. Go from the front. I still go from the front. It's
And then what?
Not going to be easy. We've done it. It's not going to be easy. I would send him vascular study, go from the front, get a really good vascular surgeon that you can trust. But once they get you there, the rest is easy. It's them getting you there, right?
Well, Neil, the good thing, it's only 4 days out.
Right.
So if you go in that day, you know, they say the worst time is between 7 and 14 days.
Right.
So, you know, and I think this, and somebody else, I think Vince Arlett or somebody said, you know, this is an anterior posterior from 4 to the sacrum. I don't think you have any other choice.
I agree.
Mike, the only thing that bothers me, and you know, it's so frustrating when this stuff happens, whether or not you'd had a bone density and whether or not she was osteopenic. I mean, sometimes this stuff just happens, but that would be the only thing that I would have been concerned about pre-op.
But that is such a bizarre fracture pattern. I mean, you almost never see that in trauma. It's almost a reportable case, you know, when you see it traumatically. So you wonder whether she had a vascular channel or, you know, some stress riser there that implantation just disturbed. So how'd you fix it, Mike?
Christina, you want to keep going?
Oh, yep, absolutely. So those are all great points. Someone on the chat brought up corpectomy as well, which is something we discussed about this case. So in this case, we started posterior and did a posterior stabilization. Like a lot of people mentioned, from 4 to 1, and then set her up for a second stage anterior procedure. So at our
vascular guy was out of town. It was a weekend. I just said, I got to fix this like a pincer fracture, and a pincer fracture that, you know, the patient can't get up. I just said, I'm going to put some screws in it. I'm going to stabilize it, and then I can get my stuff together, and come Monday, we can figure out how we're going to do something from the front.
I like it.
Okay.
So she underwent vascular evaluation with an angiogram to map out clearly her bifurcation and confluence just for preoperative planning. We do that routinely for all of our lumbar exposures with our access surgeon. And this was her on Monday, second stage anterior procedure. She had a little bit of a abdominal distension and some bruising, not atypical for her postoperative timeline. So this was interesting approach to the anterior portion of this procedure. So removed obviously the protus implant and the keeled implant, and then went through, debrided the fracture hematoma, any underlying disc within the fracture site, careful to preserve the ALL of the 4-5 level, to provide some stability to that fracture fragment. And then brought a tamp to reduce it and stabilize that with lag screws.
Whoa.
It was an interesting approach to this case. And then placed a femoral ring allograft at 5.1, and then at secondary approach up to the 4.5 level, again, preserving the ALL to theoretically preserve some sort of stability to that fracture fragment, and so approaching that for more of an anterior lateral type of exposure at the level above. And I know there are comments coming, but I'll go ahead and show some follow-up x-rays. These are her final intraoperative films. And then 3 years follow-up, and we have 6-year follow-up where she's healed well.
Mike, love it. Great approach. Good
mean,
question, though. How did you reduce that? You can't see it. You're looking from the front. Did you use X-ray to reduce it?
Yeah, I stuck the curette in, and then I went up and looked at the 4.5 level, and the vessel was laying right there, and I didn't think I could get behind the vessel to do a good corpectomy and get it in.
I love it.
So I pushed down on it with a bone tamp. That's just a bone tamp from the FRA. I was able to reduce that and saw it on x-rays. I said, I'm just going to reach in and I can get around and put 2 screws in and lag it. And then I'm going to preserve the ALL and go anterior lateral like we do in OLIF. So between the psoas and the ALL, and put the femoral ring allograft coming in the side so that whole fragment has some inherent stability. And the key is you got to get the disc out of the fracture fragment. That's why I use that curette to come up in between them to curette all the disc out. It's the problem with pincer fractures or coronal plane fractures. The disc of the superior one usually gets jammed down in, then you get a non-union because they don't heal.
Did you stent the ureter?
Yes, we always put it, anytime we do a revision, we put a stent in the ureter before we do the exposure.
Mike, that was a beautiful job. Amazing.
You made lemonade out of lemons here, Mike, and you restored a nice lordosis so that even on long-term follow-up, her 3-4 disc is hanging in there very nicely. So good work. It's a great
Learn
case.
more from the complications that you have, and those are the ones we all never forget. You know, we always remember the ones, and you follow them for a while, and that just shows you how you still maintain that kind of relationship you need with the patient when I'm still following her for 6 years afterwards. So,
Very clever.
Love it.
it's unfortunate that a person comes in with a single level disease that I could have just done a single level ALIF, and I put an arthroplasty in, caused this complication, and now ends up with a 2-level fusion. Yes, I would agree that's less than ideal, but you know, we those who cut cry, and when you have complications, we have to come up with the best solutions to try to fix them.
Oh, this is so much better than L5 corpectomy. That's a nightmare. This is really good.
Mike and Christine, thank you very much. That was a great presentation, great cases, and I think good discussion, and we got some good questions from the floor. So we all appreciate it. You did good, Mike.
All right, thank you everybody for inviting us, and have a nice week.
And remember, send your complicated cases to Mike.
Everybody stay safe.
All right, thank
Mike,
you. Bye.
great talk. Thank you.
Yeah,
Good night, everybody.
stay out of the riots.
Take care.